Hello and welcome to Insight Ophthalmology. This is Dr. Amrit and today we are talking about the visual pathway lesions. There are three important points that we should know with respect to the visual pathway lesions. The first point is that the visual fields and the retina have inverted and reversed relationship. So what does it mean is the superior part of the visual field will be represented in the inferior part of the retina, whereas the inferior part of the visual field will be represented in the superior part of the retina. Similarly, the temporal part of the visual field will be represented in the nasal part of the retina, and the nasal part of the temporal field will be represented in the temporal part of the retina. This is what is meant by the reversed and the inverted relationship between the visual fields and the retina. The second thing that you should know is what is the meaning of homonymous, okay? Because this term is used when describing the visual field. Homonymous means that both the eyes are involved with the same laterality. That means if we consider this to be the visual fields of right and left eye, in both the eyes either the right side of the visual field is affected or it is the left side of the visual field which is affected. Okay, so this is what is meant by homonymous. That means the same side is involved in both the eyes. Third point is that what is meant by congruous field defect or the incongruous field defects. Okay, so the congruous field defect means that the visual field defect is alike in both the eyes, and incongruous field defect means that if the field defect is different in two eyes, that means if we consider this to be the visual field of two eyes, if both the eyes have similar type of involvement in both the fields of vision, then it is called congruence. Suppose this is right eye, this is left eye, and both of them have similar halves which are affected. So that means it is congruence. However, if the defect looks somewhat like this, only the upper half is involved in one eye and the other eye, the entire half is involved. So these two defects cannot be superimposed on each other because they are not alike, they are different. So such a field defect is called the incongruous field defect. Now let us discuss these lesions of the visual pathway at different levels. So first, starting with the optic nerve. Whenever an optic nerve of one side is involved, either because of the optic atrophy or because of traumatic avulsion of the optic nerve or transection of the optic nerve, it will lead to almost a complete blindness of the same side. Okay, so it will lead to complete blindness of the same side. So as shown in the diagram and represented by number 1, if the left side optic nerve is affected, there will be a complete blindness on the left hand side. Along with that, the ipsilateral direct light reflex will be gone and contralateral consensual light reflex will be gone. So what do I mean to say is that if you shine a torch in the left eye, this side, the left sided pupil will not react to light. Along with that, the right side pupil also will not react to the light which is shown in the left eye. But if you show the light in the right eye, then it will still react because the right sided optic nerve is normal, right? So to revise, the left sided optic nerve lesion will lead to left side total blindness. Along with that, ipsilateral light reflex affection and contralateral consensual light reflex will be affected. Now let us look at a lesion of the optic nerve very close to the chiasma, or we can say almost at the point where the chiasm is starting, represented by number 2 in this diagram. This diagram over here represents the crossing of various fibers in the chiasm. So if we look at this over here is the optic nerve, and it is divided into 5 quadrants. That is the upper temporal quadrant, the lower temporal quadrant, the upper nasal quadrant and the lower nasal quadrant, and in the center we have the macular fibers running through. So as we already know that in the optic chiasm, it is only the nasal fibers which are going to cross and the temporal fibers do not cross and they are going to pass just like that. So the same thing can be seen that the lower temporal fibers are passing uncrossed in the chiasm and the upper temporal fibers are also passing uncrossed in the optic chiasm, and even the macular fibers are going uncrossed in the optic chiasm. However, what we should know and we should notice here, it is that the lower nasal fibers, that is represented by here. So this is the lower quadrant and it is present in the nasal side. So it is these fibers, the lower nasal fibers, they are going to come in a way that they, before crossing, they will form a genu, or they will actually take a bend in the contralateral optic nerve, and then they are going to cross to the opposite side. Now, because they are forming a loop towards the opposite side before they actually cross in the optic chiasm, this is called the Wilibrand's knee. Okay, so this is called the Wilibrand's knee. So whenever there is a affection of the optic nerve near the optic chiasm, so what might happen is that this Wilibrand knee also might get affected. Okay, corresponding defect to this Wilibrand's knee. Now, what is that defect to the Wilibrand's knee? I already told you that the Wilibrand's knee is carrying the fibers from the lower nasal part of the optic nerve, and I already told you that the representation is reversed and inverted. That means the lower nasal fibers are carrying information from the upper fields, and the nasal fibers are carrying information from the temporal field. And moreover, because crossing is present, these fibers will belong to the opposite side. So contralateral upper temporal field effect will be seen. That means that if this Wilibrand's knee is affected, in the left side we will see an upper temporal defect like this. Okay, we will see an upper temporal defect like this. Okay, but along with that, along with the affection of the Wilibrand's knee, even the optic nerve is getting affected. So what happens when the optic nerve is getting affected? We will see total blindness on the side where the optic nerve is affected, right? So such a kind of field defect where we have almost entire field of defect present on one side, and on the contralateral side we have only the upper temporal field defect present. This defect is called the junctional scotoma. Okay, this field defect is called the junctional scotoma. So let me explain this to you in this diagram. So in this diagram also, the lesion represented by number 2, we can see that the left-sided optic nerve is totally affected. So on the left side, we will see a total field defect. However, on the right side, we can see that the lower nasal fibers are coming and they are crossing and forming the Wilibrand's knee in the optic chiasm, and they might also get affected when the lesions are affecting the optic nerve near to the optic chiasm. So therefore, we will see a defect on the contralateral upper temporal field, okay, like this. And this is called junctional scotoma. It's called junctional scotoma, and it represents a lesion present in the optic nerve near to the chiasm. The third lesion, that is the lesion of the optic chiasm. Okay, and let us talk about the sagittal lesions which will affect the sagittally the optic chiasm, right, represented by number 3 over here. Now, as we already know that in the optic chiasm, it is the nasal fibers which are going to cross, and the temporal fibers do not cross and just pass uncrossed. So whenever there is a lesion affecting the central part of the optic chiasm, it will affect the nasal fibers which are crossing. So that will affect which part of the field? It will affect the temporal parts of our field. That means the temporal part of the left eye and the temporal part of the right eye will be affected. Now, since both the temporal parts are affected, such a lesion is called bitemporal, and because the halves are affected, it is called hemi, and anopia means we can't see. So a lesion of the optic chiasm which affects the central optic chiasm will lead to bitemporal hemianopia. Along with that, there will also be bitemporal hemianopic paralysis of the pupillary response. That means the pupillary response on the temporal part of the pupil will be absent. Along with that, we will see optic atrophy also. Now let me tell you one more point is that the optic nerve lesion, the optic chiasm lesion, and also the optic tract lesion, and sometimes the lateral geniculate body lesion can lead to optic atrophy also. However, when the lesions are behind the lateral geniculate body, that means in the part of visual pathway which is present behind the lateral geniculate body, the optic radiations and the visual cortex, usually the optic atrophy is absent. So the optic atrophy is present only in the lesions which are present in front of the lateral geniculate body. The same thing applies to the pupillary reflexes also. The pupillary reflex will be affected up to the level of the optic tract, because I already told you in the previous video that the pupillary reflex fibers will come out of the optic tract and go to the superior colliculus, right? So since they have already crossed before the level of the lateral geniculate body, anything which will affect the visual pathway after the level of optic tract or after the level of lateral geniculate body will not affect the pupillary reflexes, right? Now, what are the lesions which can affect the optic chiasm from the central part? So the lesions are the supracellular aneurysms, tumors of the pituitary, craniopharyngioma, supracellular meningioma, third ventricular dilatation due to hydrocephalus. Now, in order to remember this, you should actually remember the relations of the optic chiasm which I explained to you in the previous video. So what I told you was that there is a depression in the sphenoid bone in the base of the skull, and that depression is actually called the sella turcica. So in that sella turcica, what we have is our pituitary gland. Above the level of the pituitary gland is our optic chiasm, right? And above the optic chiasm we have our third ventricle, right? And on the either side of the optic chiasm, what are we having is we have the blood vessels. So any of these structures, when they get affected, so either if it's a craniopharyngioma which is coming from the third ventricle, or it is the dilatation of the third ventricle, they will come and press upon the superior aspect of the optic chiasm. Similarly, next we come to the optic chiasm lesion involving the lateral part of the optic chiasm, which is represented by number 4 over here. So it is the lateral affection. Know that the lateral part of the optic chiasm will be carrying the temporal fibers which are not getting crossed, and the central part is carrying the nasal fibers which will get crossed. So since the lateral affection will affect these temporal fibers, the field of vision which will be affected will be nasal. So it will lead to nasal field defects on both the eyes, and because it affects the nasal fields of both the eyes, it is called binasal hemianopia. Along with the binasal hemianopia, we will also have binasal hemianopic paralysis of the pupillary reflex. That means only the nasal part of the pupils will not react, and along with that we will have optic atrophy. Now let me tell you a little bit about the optic atrophy which is present in this optic chiasm lesion, is that they will not affect the entire optic nerve. Since only a part of the fibers are getting involved, that means either the temporal or the nasal, the optic atrophy will also be partial optic atrophy, right? So what are the lesions which can cause this optic chiasm affection from the lateral side? So it could be either the distension of the lateral ventricle. So the lateral ventricle the third ventricle can get distended and then can extend downwards from the either side and affect the optic chiasm laterally. Or it could be, say, an atheroma of the carotid which are present on the either side, and they can go and press on the lateral parts of the optic chiasm. Next, we will discuss about the optic tract lesions, which is represented by the number 5 in this diagram. As we know that the optic tract will carry the uncrossed temporal fibers and the cross retinal fibers. The uncrossed temporal fibers will lead to a nasal defect in the same eye, and the cross nasal fibers will cause a temporal defect in the opposite eye. Now, since the same side of both the eyes is getting affected, it is called a homonymous type of hemianopia. And one more thing that we should know is that the optic tract is the first site in the visual pathway from which the homonymous representation will actually start. And if we see from the optic tract onwards, that is the optic tract, lateral geniculate body, optic radiations, the homonymous defects will start from the optic tract. This homonymous hemianopia is actually incongruous, and I already told you in the beginning of the video that incongruous means when the visual field defects are not similar. Now you might ask that these two visual defects in the two eye, they are actually looking similar, but in reality that is not true. In reality we do not have these perfect circles. The visual fields look somewhat like this in both the eyes. That is, it is not exactly oval, it is somewhat triangular because the nasal part of the fields are smaller compared to the temporal part of the field. So if in one eye the nasal part of the field is affected in this manner, and in the other eye the temporal part of the field is affected, these two field defects will not look similar as is seen in this easy representation, right? It is different. So because they are not similar and they are different, this type of homonymous hemianopia, which is seen in the lesions of the optic tract, it is called incongruous homonymous hemianopia. So that is very important to remember. The second point is what we will see in terms of pupillary response is a hemianopic pupillary response. What does it mean is that whenever the light is shown in the part of the pupil which is affected, we will not have any light response. We will not have any constriction when we show light in the part of the pupil which is affected. Whereas when we put light in the non-blind part of the pupil, the other half of the pupil, there will be pupillary reaction. Now because such a hemianopic pupillary response is present, it is also called Wernicke's pupil. Okay, so Wernicke's pupil is a feature of lesion of the optic tract. Now along with that, there will also be optic atrophy which can be seen, and sometimes because of the close association with the midbrain which is present somewhere here, because of the close association with the midbrain, the third nerve palsy can also be present, and ipsilateral hemiplegia also might be present because of the close relationship with the third nerve nucleus and the corticospinal tracts. Now, what are the lesions which can cause this optic tract lesions? So these are, number one, they could be the tumors of the thalamus. Now, in my previous video, I told you how the optic tract is very closely present in relation to the thalamus. Or it could be the posterior cerebral artery aneurysms or the superior cerebellar artery aneurysms. We know that the posterior the cerebral artery will be coming like this, and the superior cerebellar arteries will be going somewhere like this. So the aneurysms of these arteries can also affect the optic tract. Along with that, infections like syphilis and tuberculosis, they can also have a role in optic tract lesions. Next in line are the lesions of the lateral geniculate body, which is represented by number 6 in this diagram. So lateral geniculate body are the endings of the optic tract, and the arrangement of the fibers is also the same. So they are also carrying the same uncrossed fibers from the temporal retina and causing a nasal defect in one eye, the ipsilateral eye, and the crossed fibers which are nasal fibers and which will cause a temporal field defect in the opposite eye. So since they are also affecting the same side of the visual field in both the eyes, they will also cause homonymous hemianopia of the incongruous variety. But there is a difference between the visual field defect of the optic tract and the visual field defect of the lateral geniculate body, although both of them are causing homonymous hemianopia. And the difference is that in the lateral geniculate body, there will be sparing of the pupillary reflex. And why is it so? Because as we have already seen that the pupillary fibers will come out of the optic tract and will go to the superior colliculus present in the midbrain much before the lateral geniculate body. So the lateral geniculate body does not receive any pupillary fibers, because of which there will not be any affection to the pupillary reflex in case of lateral geniculate body lesions. Also, there might be a partial optic atrophy present in case of lateral geniculate body. Now, there are certain advanced visual field defects which can be of congruous variety also, like the sectronopia and the quadruple sectronopia, which can be seen in lesions of the lateral geniculate body. However, they are quite advanced to explain and they are outside the scope of this video. However, if you want me to make a video on that, kindly comment in the comment section. Discussing the lesions of the optic radiations. Their features will vary depending upon the site of lesion. For the purpose of simplicity, let us talk about number 7 first. That means the fibers which are arching along the lateral ventricle inferior lobe. So, as I explained it to you in my previous video on the anatomy of visual pathway, that few fibers of the optic radiation will arch along the lateral ventricle and travel in the inferior lobe of the brain, that is the temporal lobe. Since these fibers are present inferiorly, they will carry the information from the contralateral superior part of the visual field. And affection of this part of the optic radiation, which is also called the Mayer's loop, will lead to contralateral defect. These Mayer's loop or the inferior fibers are carrying information from the superior part of the retina. They will cause a superior defect, and since the left-sided optic radiation is affected, it will cause a defect on the right side. So it will lead to right-sided superior 1/4 defect, and this is called the pie in the sky defect. This pie in the sky defect is seen whenever there is a lesion in the Mayer's loop, that is nothing but the inferior fibers of the optic radiation traveling in the temporal lobe. Now, there were also fibers which are going to pass straight away traveling superiorly into the parietal lobe and going up to the calcarine fissure. So these superior fibers were carrying information from the lower part of the visual field, and they are called the Baum's loop. And affection of this Baum's loop will cause an inferior field defect, and because the left optic radiation is affected, the right visual field of the inferior part will be affected. Okay, and this defect is called the pie on the floor. So pie on the floor is seen whenever the Baum's loop is affected or the superior part of the optic radiation is affected, which is shown in this number 8. Now what will happen when the entire optic radiation will be affected? Then both the pies will fuse with each other, and we will see something which is very similar to what is seen in the lateral geniculate body lesion or in the optic tract region. That is, we will see incongruous homonymous hemianopia of the contralateral side. Will the pupillary reflex will be affected? The answer is no. Since the pupillary fibers have already separated right from the optic tract, anything behind that will not affect the pupillary fibers, and there will be no RAPD, there will be no effect on the pupillary reflex. This is now about the visual cortex lesions, which are represented by the number 10 and 11. We must have a brief knowledge about the blood supply of the visual cortex. So the visual cortex is getting its blood supply mainly from the posterior cerebral artery and from the middle cerebral artery. So both the carotid system and the vertebral system is actually contributing to the blood supply of the visual cortex. Moreover, the tip of the occipital lobe, or the part where actually the visual cortex is present, the maximum number of fibers are representing the macula. In other words, we can say that the macular fibers have the maximum area occupied in the occipital lobe or in the visual cortex. And as can be seen clearly in this diagram, that the posterior cerebral artery and the middle cerebral artery both are supplying the macular area. Our posterior cerebral artery supplies most of the anterior part of the visual cortex. So whenever there is a stroke involving the posterior cerebral artery, almost the entire visual cortex will be affected except the macular part. So in such a case, we will see a homonymous hemianopia, but there will be sparing of the macula, right? So we will see a contralateral homonymous hemianopia sparing the macula. Now, why is the macula spared? The macula is spared because the macula is also getting its blood supply from the middle cerebral artery, and it is perfused even in case of a posterior cerebral artery stroke because of the dual blood supply present to the macular area. There will be macular sparing. Okay. Now, the next question is this defect congruous or incongruous? So when we reach the visual cortex, the defect will become congruous. Okay, the defects in both the eyes will become more alike. And why is it so? It happens because in the optic radiation, the fibers are actually radiating, and after radiating, as they reach the visual cortex, they will converge to a particular point. So as the fibers come together, they're coming more together and they are becoming more alike. The visual field is becoming more alike. However, in the case of optic radiation, because the fibers were more apart, the visual field defect was also incongruous. The defect that we see in posterior cerebral artery stroke is congruous homonymous hemianopia, which is sparing the macula. There is an injury which is affecting directly the tip of the occipital lobe as such. In case of a head injury which is affecting the tip of the occipital lobe where the macular fibers are present, or sometimes a gunshot injury also, okay, where the bullet directly goes and hits the tip of the occipital cortex. So over there the macular fibers will get affected, and in such a condition what we are going to get is we will get congruous homonymous macular defects on the contralateral side, okay, as shown in this picture. Finally, we will not see any optic atrophy or any problems in the pupillary light reflex in the visual cortex lesions. So this was about the visual pathway lesions. Any doubts you can ask in the comment section. Thank you and have a nice day.